So next, let's start with hematology. So we'll first start with platelets. So under this, we'll be first discussing the normal hemostasis. Then we'll see about the various bleeding disorders. So what is normal hemostasis? So whenever we get an injury, a bleed, so how does that bleeding stop? So that is what means as hemostasis. So bleeding is going to stop. So the initial, it can be divided into three phases. The initial phase is going to be a vasoconstriction. So vasoconstriction is ideally going to happen in the arterioles, and it is going to be a reflex neurogenic mechanism. So reflex neurogenic mechanisms will come into play and cause immediate vasoconstriction. So the first event will be vasoconstriction. The second event is going to be formation of a primary hemostatic plug with the help of platelets. So platelets come into play in the primary hemostatic plug. In the secondary hemostasis, it is going to be the formation of fibrin clot. So coagulation cascade will get activated, and that will result in the formation of the fibrin clot. Okay, so let's see about the primary hemostasis first. So whenever there is going to be an endothelial injury, a vessel injury, so the endothelial injury is there, so the subendothelial collagen is going to get exposed. So in the subendothelial location, we also have the von Willebrand factor. So von Willebrand factor is going to be present at the endothelium, especially in the Weibel pellet bodies. So WPM writing, so Weibel pellet bodies is the location of the von Willebrand factor normally. Then from this Weibel pellet bodies, this von Willebrand factor is going to be secreted into the plasma, and also they will come and rest onto the subendothelial location. Apart from this, von Willebrand factor is also present in the platelets and megakaryocytes. Okay, megakaryocytes are the precursors of platelets. So platelets and megakaryocytes are also the site of production of von Willebrand factor. So this, when there is an endothelial injury, the subendothelial collagen along with the von Willebrand factor is going to be exposed. Now what happens? The platelets will come, which were inside the blood vessel, they will come and attach to this subendothelial collagen and von Willebrand factor. So this step is what we call as platelet adhesion. So the adhesion is actually taking place between the platelet glycoproteins. So platelet glycoprotein 1b and 9 is going to attach with the von Willebrand factor in the subendothelial location, while the glycoprotein 1a and 2a is going to attach with the collagen, subendothelial collagen. Okay. So this step is what we call as platelet adhesion. So next step will be platelet activation. Once it has got adhered to this subendothelial collagen and von Willebrand factor, the platelets will get activated. So platelet activation includes two steps. First one will be the shape change of the platelets. Second one will be a release reaction. So in shape change, normally we know that platelets are going to be disc shape, right? So the disc shape platelets, they are going to change their shape into a sea urchin kind of thing. So normally it is going to be like this. Now the shape is going to become like this, so that the surface area of the platelets is going to be increased. So spiky kind of a surface is formed like a sea urchin. Okay. So this transformation of the shape change is going to, why does it happen? Because it is going to cause a change in the phospholipid membranes also. So the phospholipid membrane of the platelets is also going to get altered in the way the phosphatidylserine, which is normally present in the inner leaflet of the plasma membrane, is now going to come to the outer surface, just like in apoptosis. Okay, so phosphatidylserine is going to come to the outer surface, and when it comes to the outer surface, it is going to create a negative surface charge. Okay, there is going to be a negative charge created when this phosphatidylserine comes out. So this negative charge is very much important, because only onto the negative charge the clotting factors can come and attach and initiate the clotting cascade. Okay, so this platelet activation is going to involve the shape change, wherein there is a membrane flipping along with the formation of the sea urchin kind of morphology. Then the next step in the platelet activation is going to be a release reaction. So release reaction is nothing but the platelet granules are going to be released. Okay, so the various platelet granules are alpha granules and dense granules. That's we'll see next. Okay, so the contents of the granules will be seeing. So the granules are being released, and one of the granule content in the dense granule is going to be ADP. So this ADP is again going to cause platelet adhesion. Okay, ADP released from the platelets is again going to cause platelet adhesion. So this is a cycle. So platelet adhesion, so auto coagulation kind of a cycle is going to happen over here. Then after this platelet is getting activated, next up is the platelet aggregation. So with one platelet, another platelet is going to come and attach. So it is going to form a platelet aggregate. So this interaction is going to take place with the help of glycoprotein 2B3A. So glycoprotein 2B3A is present in the platelets. So two platelets are going to be here. So many platelets are here like this. So all of this is going to have this glycoprotein 2B3A. So all of this is going to get attached with the help of a fibrinogen. So fibrinogen is going to help in bridging this platelets. Okay. So remember, platelet addition is going to be glycoprotein 1B9 with von Willebrand factor and 1A2A with collagen, while platelet aggregation is going to be between glycoprotein 2B3A and along with that fibrinogen is going to form the bridges between the platelet. Okay, so this aggregation has taken place, so it is going to form the primary platelet plug. Okay, now this is the primary hemostatic plug. So let me discuss the platelet granules again. So the platelet granules are divided into alpha granules and dense or the delta granules. In alpha granules, you are going to have the von Willebrand factor. So I mentioned platelet is a source, right? So von Willebrand factor, factor 5, fibrinogen, fibronectin, P-selectins, PDGF, TGF-beta and platelet factor 4. So all of this is going to be present in the alpha granules. Dense granules or delta granules, here it is the ATP, ADP, calcium, serotonin and epinephrine which are present in the dense granules. So this is the ADP I mentioned, which is released during the release reaction, going and auto-activating the platelet addition. Okay. So now we have seen the primary hemostasis. Now let's see the secondary hemostasis. Same thing. So when the vessel was injured, in the subendothelial location, apart from the collagen and von Willebrand factor, there is also a tissue factor. So tissue factor is going to be a clotting factor, right? So it is clotting factor 3. So this is going to be exposed. So subendothelial tissue factor is getting exposed. So whenever factor 3 is tissue factor is exposed, it is going to activate the extrinsic pathway, extrinsic coagulation pathway. Okay. So the tissue factor in the extrinsic pathway will react with the factor 7, which is again a coagulation factor. So factor 7, and then they will form the complex, and that is going to enter into the common coagulation cascade starting from factor 10. So we'll be discussing the coagulation cascade shortly. So once coagulation cascade is activated, it will result in the autocatalytic reactions, final product of which is going to be a stable fibrin clot. Okay, stable fibrin clot is going to be formed. So this is the final product of the clotting mechanism. Okay, now let's see the coagulation pathway. So coagulation pathway is going to be of two pathways, intrinsic pathway and extrinsic pathway. Intrinsic pathway is usually happening in the in vitro stages. So inside the body, it is usually the extrinsic pathway, that is the in vivo pathway. So this is what we were discussing. Tissue factor is getting activated as it is present in the subendothelial location, activating factor 7, and this together complex, this is going to activate the common pathway, which is factor 10. Okay. An intrinsic pathway, if you see, there is whenever the clotting factors come into a negatively charged surface, like glass beads, as we use in the in vitro testing. So in this kind of scenario, the factor 12 is the initial factor in intrinsic factor pathway. So this factor 12 is getting activated. So this is an autocatalytic chain resulting in the activation of factor 11, then factor 9, then with the help of factor 8, final product of factor 10A is going to be formed. So till factor 10A, it is the intrinsic pathway. So this from factor 12 to factor 10, this is the intrinsic pathway here. While this factor 3 and factor 7 together here, till here it is the extrinsic pathway. So together they had culminated in the formation of active factor 10, from which we have the common pathway. So in common pathway, factor 10A is going to be acted upon by two other factors, which is factor 5A and calcium. So calcium is also a clotting factor. So calcium is actually needed for every step seen in both the intrinsic and the extrinsic pathway. So together everywhere calcium is present. So this final step also calcium is needed along with the factor 5A. So with the help of this, factor 10A is going to convert prothrombin, which is factor 2, into thrombin. So this thrombin is then converting the fibrinogen, which is factor 1, into fibrin. So this fibrin will then be acted upon by activated factor 13, and then it is going to form a stable fibrin clot. So factor 13 is going to cause cross-linking of this fibrin, forming a stable fibrin clot. So this thrombin here, so the fibrin was the main product, but thrombin here is going to have multiple action. So what is the action of this thrombin? Firstly, it is going to convert this fibrinogen. So it is there for the fibrin formation. Fibrinogen to fibrin is there, right? Secondly, it is going to activate factor 13. So factor 13 is going to be activated into factor 13A, and that is causing the cross-linking of the fibrin. So that is the second action. Thirdly, it is going to activate protease activated receptor. So in inflammation chapter also I was discussing this under inflammatory mediators. This thrombins is going to activate the protease activating receptor. This protease activated receptor is going to be present on both WBCs and platelets. So when this WBCs are when it is going to activate this PAR on WBCs, it will recruit the WBCs. So inflammation is also going to come around this place. And when it is going to act on this PAR1 on platelets, it was going to activate the platelet adhesion. Okay, so here again it is going to help in the formation of primary hemostatic plaque. So everything is going to be interlinked here, inflammation and coagulation. So this is the third action of thrombin, and as such, if you this thrombin is also going to act as an anticoagulant. So clotting is actually a coagulating pathway, but it in normal conditions, that is when the endothelium is not damaged, in a normal state, this thrombin will act as an anticoagulant. Okay, so I'll be telling that in detail again now. So till now we had seen the formation of the stable fibrin clot. So after this, once the bleeding has stopped with the help of this fibrin clot, the bleeding has to, the clot formation has to stop, right? It has to go back to its normal state. So and during that, fibrinolysis pathway is going to be activated. So for fibrinolysis, there is a protein called as plasminogen. This plasminogen is in turn being activated by factor 12 again here. And then along with that, we have tissue plasminogen activator. So tissue plasminogen activator and factor 12 will act upon this plasminogen and convert it into plasmin. And this plasmin will act on this formed fibrin clot, and then it will degrade it into fibrin degradation products. So fibrin degradation products, examples are fibrin degradation product D-dimer, and along with that, it can also act on the fibrinogen producing fibrinogen degradation products as well. So fibrin and fibrinogen degradation products along with D-dimers are going to be produced by the action of plasmin. So how does this fibrinolysis get stopped? So everything needs some regulatory check, right? So this fibrinolysis also has a check. So tissue plasminogen activator is going to be inhibited by another protein called as plasminogen activator inhibitor. So this is tissue plasminogen activator is PA, right? So inhibitor to this PA will be plasminogen activator inhibitor. Then we also have another inhibitor for inhibiting this plasmin, that is going to be alpha-2 plasmin inhibitor. Okay, with the help of this fibrinolysis pathway is also being regulated and kept under a check. So this is the normal coagulation pathway which is happening. So let's see the normal state. So how does this come to the normalcy? In a normal state, when there is no endothelial injury or when this clotting has been completed, what happens is we have anticoagulant mechanisms. The first one will be a thrombomodulin. A thrombomodulin, as the name suggests, it is going to modulate the action of the thrombin. Okay, so this thrombomodulin is going to interact with the thrombin, and it is going to activate a anticoagulant protein called as protein C. So for the action of protein C, we need a specific cofactor which is called as protein S. Okay, so protein C and protein S are going to be recruited and activated, and this protein C and protein S is together going to inhibit activated factor 5A and activator factor 8A. Okay, so 5 was needed in the common pathway for conversion of factor 10 to 10A, and factor 8 is again involved in the formation of the factor 10 itself, right? So these two are going to be called as the labile factors. Okay, labile factors because normally in the fresh frozen plasma FFPs, we are going to have all kind of clotting factors, right? But this factor 5 and 8 are not going to be present in that because they are quite labile and they are lost easily. So factor 5 and 8 will not be present in fresh frozen plasma in the normal amounts. Okay. So this mechanism we understood, right? Thrombomodulin interacting with thrombin and activating protein C and protein S. Now together they are going to inhibit this factor 5 and factor 8. So this is why I mentioned that thrombin is an anticoagulant in the normal state. Okay, both coagulant and an anticoagulant action of thrombin is there. Then the second mechanism is there is going to be heparin-like molecule, which is again an anticoagulant. It is going to react with the antithrombin 3. So as the name suggests here, it is going to be antithrombin. So against thrombin. So this is going to interact with this antithrombin 3 and this will inhibit the thrombin as the name suggests. Along with that, factor 9, 10, 11 and 12. Okay, 9, 10, 11, 12 and thrombin are going to be inhibited by the interaction of heparin-like molecules with antithrombin 3. So, whenever we are giving this heparin treatment, right? So, for patients we are treating with heparin, it is going to actually act upon this antithrombin 3. So, it is basically acting like heparin-like molecule. So, this name has actually come from this, okay. So, heparin is going to act on this antithrombin 3 and cause the inhibition of thrombin and factor 9, 10, 11 and 12. Then, the third mechanism of anticoagulation will be the tissue factor pathway inhibitor. So, this tissue factor pathway inhibitor, as the name suggests, it is going to inhibit the extrinsic pathway. It is going to inhibit the extrinsic pathway, tissue factor pathway inhibitor. So, this again is going to need the cofactor, which is protein S. So, along with that, it is going to inhibit the tissue factor 7A complex, right? So, these three mechanisms are the anticoagulant mechanisms. Apart from that, we also have vitamin K dependent factors. So, vitamin K is needed for the certain reactions which happen in certain coagulation factors, which are factor 2, 7, 9 and 10. Okay. So, factors 2, 7, 9, 10 are going to be dependent on vitamin K, and whenever you are giving coumarin derivatives, so treatment like heparin, coumarin is also a drug. So, coumarin derivatives, if you give, it is going to act upon this vitamin K dependent factors only. So, it is going to inhibit these ones. Okay. Now, we had seen about the normal coagulation cascade and along with the normal hemostasis. One thing I forgot to mention here. So, this intrinsic pathway and extrinsic pathway, we are going to test with the help of certain coagulation tests. So, whenever we mean coagulation profile, we are going to mean the basic test, which is platelet count initially. So, platelet count is needed for determining the action of the primary hemostatic plug. So, when platelet count is going to be less, platelet plug is not going to be formed. So, platelet count is needed. Then we also have bleeding time and clotting time. So, bleeding time is usually abnormal when there is a platelet defect. Okay. So, in coagulation profile, you are going to have firstly platelet count. Then we have bleeding time. So, bleeding time is going to be abnormal whenever there is either platelet number is deficient or when the platelet function is defective. Okay. So, anything related with the platelet, bleeding time is going to go abnormal. Then we have clotting time, which is going to go abnormal in the clotting factor deficiencies. So, clotting cascade is going to be deficient. So, in that, clotting time is going to be abnormal, elevated basically. Then we have prothrombin time and activated partial thromboplastin time. Okay. So, this prothrombin time PT is going to be elevated in the factors involved in extrinsic pathway. So, in extrinsic pathway defects, PT will be elevated, while APTT is going to be elevated in intrinsic pathway defects. Okay. Apart from this, we are going to use the INR ratio also. So, these form the basic tests under the basic screening test for any coagulation profile. Okay. So, any bleeding disorders, you will have to do these tests. So, whenever we are discussing the bleeding disorders, we will be discussing under these findings. Okay. So, how do you remember this PT and APTT? So, I remember it this way. So, PT period, we play it in the external environment, right? In the ground. So, PT for external, EX. So, PTE, you can also call it as PT, PT examination, right? So, this is how I remember it. So, PT is for extrinsic pathway, while APTT is for intrinsic pathway. The normal platelet count is going to be 1.5 lakh to 4 lakh. So, less than 1.5 lakh, it is going to cause thrombocytopenia and bleeding disorder. Then, BT time, it varies with the method, but usually remember 2 to 5 minutes is the normal range in IV method. Okay. And then clotting time, they usually don't mention it. For PT, it is going to be, normal is going to be 11 to 16 seconds. APTT, the normal is going to be 30 to 40 seconds. Right.